Well, first of all, we'll look at the ECG from the last video on ST segments. So we'll look at, first of all, the rhythm. So the rhythm, we can see that it's pretty regular. It's every 4 big squares. So that's about 75 beats per minute. Then we can look at the P waves. We always look at lead 2 and V1. Upright in both those leads, which is a good sign, means that there's a normal P wave axis. It's most likely coming from the sinoatrial node. The PR interval is around about 200 milliseconds. I'd say I'm happy with that. And there's a P wave for every QRS complex. That's good. The QRS complex itself, that's narrow, so it's less than 3 small squares or 120 milliseconds. And the QT interval, so let's say roughly that's the QT. Quick way to work out that the QT is normal. You have the QRS complex. The QT interval is less than half of the QRS to QRS, so we can say that that's most likely normal. After the QT, then we're going to look at the axis, and in leads 1 it's predominantly positive, and also in AVF it's predominantly positive deflections, so we can say that the axis is normal. Following the axis, we move on to the ST segment, and in this case we've actually got ST segment elevation that's very concerning for an acute occlusion. If you remember back to the criteria from the European Society of Cardiology that I showed you, it talks about a bit of leniency in V2 and V3. We can have a little bit more ST elevation in leads 2 and V3 that could be considered normal, and that depends on if you're a male or female and if you're under or above 40 years old. But in this case, actually, the ST segment elevation is pretty significant. We'll measure it at the J point, and it comes out at about 2.5 millimeters, which would fit the criteria. And definitely in V4 and V5 and all the rest of the leads, you only need 1 millimeter, and I would say we have that. Okay, so this is concerning for an acute occlusion, and these are the anterior leads. So these are the precordial leads, V1 to V6, V1 to V2, septal leads typically, V3, V4, anterior leads, and V5, V6 would be the lateral. Also AVL, and 1 is also lateral as well. Sometimes that's called the high lateral, but we'll talk about this in great detail in a later video. So now we're going to move on to T waves. So just a quick note about what the T wave should look like before we start talking about abnormal T waves. So the T wave should actually be asymmetrical. So if you look here, it's a slightly gradual upslope and then a steeper downslope. So that's actually normal. It should also be relatively small with respect to the QRS wave. So if you've got a bit of a chunky T wave like that, that might signal abnormality. Or alternatively, if you have a very tall T wave in comparison to the QRS, that would also be abnormal as well. We should also have, like I was saying, this gradual slope. It can sometimes be a bit more smooth and a bit more of a concave upslope. It can even look like ST elevation in some cases, and we'll get to that in a later lecture. But sometimes the first manifestation of an acute occlusion is the gradual T wave or the ST or the T wave upstroke flattening. I'd say that's probably the best word for it. T wave upstroke flattening here, and then slowly that can progress to a bit of tombstoning, a bit of ST elevation. But so what we need to remember, it should be asymmetric and it should be small with respect to the QRS wave. The other concerning thing about T waves is T wave inversion. T wave inversion is actually a pretty aspecific sign. We can find it in a variety of different pathologies, and I'll show you on the next slide. But new T wave inversion So say if we had an ECG on admission that showed a normal T wave, and then we took a repeat ECG and we could see T wave inversion, then that may represent ischemia, and that would be something to be concerned about. However, it's not such a specific sign compared to ST elevation. So T wave inversion, new T wave inversions we should always exclude ischemia or potentially an occlusion. So here are some of the causes of T wave inversions. So we can get it with ischemia, like I was saying. You can get it with medications. You can get it with electrolyte abnormalities, bundle branch blocks, and there it's a normal variant. Normally you expect a discordant T wave when you have a bundle branch block, and that's a normal variant. When I say discordant, I mean going in the opposite direction to the QRS complex. You can also find it in heart failure, it's very common, and also lung pathology like pulmonary embolism, COPD. It can actually also be a normal variant. So T-wave inversions can be a normal variant. I'll show you where that can be a normal variant in just a moment's time. And also CNS injury, so central nervous system injury. Here we expect to see deep negative T-wave inversions. So this is actually a normal ECG. It's slightly it's got an irregular rhythm, but really what I'm going to focus on here is where the T waves are expected to be negative. So in AVR is at 150, minus 150, so that's going in that direction towards the right atrium. So that we're normally going to expect negative QRS, negative P, and also a negative T wave. So AVR, negative T waves are absolutely fine. AVL is at negative 30. We can also get negative T waves here. Again, that's a normal variant. V1, it's very common to get negative T waves. So these are the septal leads going this way, coming out of the plane of the screen. And again, normal T wave inversion is a normal variant in this lead. Lead V2, we can get T-wave inversion. It's not as common as V1 T-wave inversion, but it's something that you'll see. It's something quite common. Sometimes it might just be because of incorrect lead placement when taking the ECG, but otherwise it might just be a normal variant. So it's not something to be too concerned about if there's T-wave inversion in V2. However, if it extends beyond V2, so if you had T-wave inversion in V3 and V4, you would definitely want to investigate that. Can sometimes be a normal variant, but it would be something that you'd want to investigate. T-wave inversions beyond lead 4, even more abnormal, even more rare in a normal person, and that would definitely be something where we want to rule out potential pathology. I'm not just talking about ischemia, I'm also talking about other types of heart disease, things like cardiomyopathy and causes of sudden cardiac death, things like Brugada, arrhythmogenic right ventricular dysplasia, and other causes of syncope and sudden cardiac death. So what I want you to take away from here is that T-wave inversion in AVR, AVL, V1, and sometimes V2 is normal, but T-wave inversion beyond V2, you always need to be concerned about. So in this case, this is an example of some deep T-wave inversion in, well, we've got it in V2, V3, V4, V5, V6, and this was actually an example of ACS. I think if I remember correctly, this was actually a patient who did have a STEMI. Next, oh, there we go. So next, this is actually an example of, well, we see some ST depression, and in this case, it was representative of some subendocardial ischemia. And we also see these giant T waves. So these are what we call hyperacute T waves. And this is one of the first signs, or can be one of the first signs, of an acute occlusion. So of infarcted myocardium. Or maybe that's actually the incorrect terminology, because this is still the early phase where perhaps the tissue isn't fully infarcted and the tissue is ischemic. So that's a much better way of looking at hyperacute T waves. This is an early part of the process where we have ischemic tissue. Here you see the ST depression, so subendocardial ischemia, and then we have these giant T waves. So we have a wide base, which is very important in hyperacute T waves, and we have a large T wave, so a large area under the curve with respect to the QRS. So it doesn't actually always necessarily have to be tall. It just needs to be wide base or a large area under the curve with respect to the QRS complex. So hyperacute T wave. So these can happen even in the first 30 minutes following an acute occlusion. Next, this example, we can see, my presentation's skipping ahead today. So next we can see some examples of tented or peaked T waves. So this is a classic manifestation that is almost pathognomonic for hyperkalemia. So typically this is one of the first ECG manifestations of hyperkalemia, and it tends to occur after after potassium levels at 6. What would the units be for that? Would it be 6 milliequivalents, I believe? So above 6 milliequivalents, you would tend to start seeing this abnormality. Not always on the ECG, because a lot of the ECG changes occur due to changes in electrolyte concentration, not just the absolute concentration itself. But here we see the tented or peaked T waves. So the next thing that I wanted to talk about was something that I don't think a lot of people understand, and it is called R-wave progression. And what we're talking about is the progression of the QRS complex in the precordial leads from V1 to V6. So in V1, typically we have a negative QRS complex, or a predominant S wave is what we call it. And by the end, V6, we expect to find a predominant R wave, or a positive QRS complex. So this is called the R wave progression. And a normal R wave progression, we would expect to see the R wave start to predominate between V3 and V4. So what I mean when I'm saying that is the R wave should take over in V3 or V4. So the R wave should now be greater than the S wave. So this is the R and this is the S wave. So if this happens in V3 or V4, then this is fine. This is normal R wave progression. So this is part of the how we define R wave progression. If R is greater than S in V3 or V4. The other thing, the other way sometimes people refer to it is if the R wave in V3 is greater or equal to 3 small squares, or 3
millimeters or millivolts, however you want to say. So if it satisfies one of these two criteria, then we can say that it's normal R-wave progression. If, however, we got to V4 and still we only had a tiny R wave and we had a big S wave, and again in V5 we had a little bit more, but not really a significant difference, and then finally when we got to V6, finally we saw the R wave take over, then this would be called poor R wave progression. It's not such a specific sign, but it can be found in a myocardial infarction, even a past myocardial infarction. Something that I just wanted to clear up, because I don't think many people understand what people refer to when they say poor R-wave progression. You can also find it in normal individuals. Sometimes it's in something called dextrocardia, which is where the heart is rotated slightly to the right side. And I'll leave you with this ECG if you can try and go through the step-by-step process, and we'll discuss this one in the next video.